This is FX Radio and I'm Andrew Whitfield Cook. And with me on the line today is Dr Jerome Sarris, who's a Senior Research Fellow at the University of Melbourne in the Department of Psychiatry. And he's also an Adjunct Fellow, a Research Fellow at the Centre for Psychopharmacology at Swinburne University of Technology. Welcome, Jerome.
Thank you. Glad to be with you, Andrew.
First, tell me about your history, because I've seen your career blossom over the past decade, or maybe a little bit longer than that. It's very exciting.
Blossoming. Well, that sounds fantastic. Look, absolutely. Look, it has been quite a ride. And I suppose, I started out back in the early 90s, which probably gives away my age a bit, at ACNM. Started off actually studying massage and aromatherapy in a wooden shed. Mm-hmm. Funny enough, when I was completing school, not when I was 8 years old. And just went through a bit of a roller coaster of learning and ended up practicing as a naturopath and as an acupuncturist, and then went on to do more academic work. Found out that I enjoyed it more than clinical work, so I went on to do a master's and then a doctorate in the field of psychiatry at UQ, and then was lucky enough to go over for my postdoc down to Melbourne University, and also spent some time over at Harvard Medical School. So it's been quite a journey, and really just all concerning my passion, which is mental health and having an integrative and complementary medicine approach to better people's mental health and to treat psychiatric disorders. So it's been quite a journey, and one which is still going on.
Yeah. Tell me about how you were accepted into psychiatry at University of Queensland, because it's not very common that happens.
Yes, look, it's one of those things where I think there is a stigma which really shouldn't necessarily be of as much concern as it can be for the complementary medicine profession, that we really feel as if, we are outsiders. In some ways we are, but I did actually find it quite accepting in terms of meeting up with some really great professors, some fantastic supervisors in the area of psychiatry and also ones connected to psychology. And look, as long as you're a reasonably bright person, as long as you work hard, you're passionate, and you can actually apply scientific methodology to the research which you're doing, certainly they're very open and very welcoming.
Yeah. So we're going to be talking about two facets of many that exist in psychiatric illness, but two which commonly present to practitioners for help in their clinics, and that's anxiety and depression. And each of those has their own set of symptoms and variations. So I might talk about differential diagnosis a little bit later, but let's go straight into depression now. When you're talking about depression, what are the major presenting symptoms that you'll actually see in a patient?
Well, according to diagnostic criteria, it's important for clinicians to recognise two key attributes, and that's one, to screen patients if they're experiencing a low mood. So basically they're not happy. They're reporting that they obviously, in basic terms, have a low mood. The second one is that they have a loss of pleasure or interest in life. So according to guidelines, they'll usually have a combination of one or both of those key symptoms ongoing for over 2 weeks. Mm-hmm. So it isn't necessarily to do with a labile affect in terms of just sort of having a crappy day. It's an ongoing presentation of low mood and or loss of pleasure. And it'll usually be accompanied by signs and symptoms such as poor sleep, people may be over or under eating, maybe a case that they may feel a lack of self-worth, be pessimistic in life, have potentially suicidal ideation. So it's very important to screen if there are any suicidal thoughts or plans. It's also important to screen for if a person has any high points, so sort of hypomanic or manic presentations, because they may actually be presenting in the depressive phase of bipolar disorder. But there's a range of signs and symptoms, and I think it's important to really focus on those two in terms of a clinician having, I suppose, a basic understanding of depression and its diagnosis.
And just a quick question about red flags, the suicidal ideation and a potential to be to have a symptomatology presenting where it might actually be bipolar rather than depression. What advice would you give to naturopathic clinicians to say this is appropriate time to refer?
Well, as I said, I mean, the problem which we're getting, and this also happens in general practice, is a person may be coming in a depressive phase of their bipolar disorder. So it's important to screen for if they have had any manic symptoms. So it's as simple as asking, have you had a period of time outside your depression whereby you may have had a period of, say, racing thoughts, of grandiosity, of increased goal setting, decreased sleep, increased activities such as sexual activities, spending. Now, minor variations of that, are not necessarily that troubling. It's when it actually interferes with a person's life, and to the point where, for example, they may actually have some psychotic presentations, in which case usually the person may end up being hospitalised. So in terms of if you start seeing any psychotic symptoms, then absolutely referral is a must. But it's very important, I think, just generally, if dealing with more of the severe mental illness such as bipolar type 1 disorder, where a person, as I said, may have manic hospitalisable symptoms, also conditions such as schizophrenia, that really is an integrative approach in concert with a medical practitioner.
How would you differentiate between depression as a diagnosis and unhappiness or sadness?
Sure. Well, I mean, you could do an entire podcast on that. Certainly from an existential position, we all go through sadness. Some basic melancholia is part of the human condition, but it has to be differentiated from clinical depression, whereby a person, will have ongoing levels of low mood or loss of pleasure in life. And look, sometimes this may be linked to a grieving process. Now, current diagnosis is saying, or diagnostic framework is saying you can still be depressed even within the early stages of grief. It's a very controversial situation at the moment with that. My personal sense is, and this is, everybody's got a different opinion on it, is that yes, you can actually have a discrete depressive episode co-occurring while a person's grieving. However, you can also have a situation where somebody is grieving and displaying signs and symptoms of depression, but it's not actually a biological clinical depression. I think probably the easiest way to tease that apart in terms of what is, say, general sadness or melancholia to do with life events or to do with grieving, to do with the attribute of self-worth. So if a person presents diagnostically with low mood, they've had maybe some rough things going on in their life, and you say, well, how do you feel about yourself? And they say, no, my self-esteem is great. No, I feel pretty positive about myself. I feel pretty positive about my future. I'm just going through a bit of a rough time. Well, that's a human condition, and I think that's something which should be supported through psychosocial interventions rather than medication.
Great advice. So let's jump into now the herbs and nutrients that you've used and indeed are researching currently. Tell me about the newer evidence that's sort of presenting itself with regards to, let's start with fish oil. Sure. Certainly there has been a lot of research done over the years on omega-3 fish oils for major depressive disorder. Now, this could be as monotherapies, so by themselves versus placebo, or as adjunctive therapies in combination with antidepressants. And, the evidence tends to support omega-3 fatty acids as having a role with improving mood, certainly as adjunctive as well. Tends to be even stronger evidence. However, it tends to be the EPA, which is the more of the efficacious fatty acid compared to the DHA. So that's where the evidence tends to support is EPA or EPA-rich formulations for depression. Yeah, and I might just give a little accolade here. There's some very important done by Maria Macready's and her Domino group at Flinders Medical Centre in South Australia on this. So with regards to fish oil and the high EPA mix, if you like, what dose do you require to get positive effect? Well, this is the thing. I mean, many trials, all the trials, I should say, have varying doses. So there's no set answer on what is the ideal dose. But I guess you'd say the rule of thumb, in terms of you weigh up the evidence, is about a gram of EPA per day should be sufficient to get a therapeutic effect. Great. And any caveats with that? Any warnings? Well, not really, except the overall fish oil advice, which is to have preparations which are enteric coated, which have vitamin E added,
so make sure that the fatty acids aren't oxidised, and in some cases vitamin C, because the vitamin C has a protective effect on the vitamin E. In terms of types of fish, I mean, most of what I understand tends to be, I think, sort of anchovies processed around Scandinavia. I mean, there's no evidence of saying that wild fish oil or salmon is necessarily better than tuna, or tuna is better than anchovies. I mean, at the end of the day, it's fairly highly purified nowadays.
Yeah, I think that comes into a sustainability issue rather than the actual fats that we get from them. Yeah. Okay, so moving on. Next one is probably the best known herb for use in depression. That's St John's wort. What's the evidence with regards to these beautiful preparations, the German phytopharmaceuticals, that have done a lot of the work, and I've got to say a lot of very good work, versus traditional use of St John's wort?
Yeah, look, absolutely. This is a vexed point, certainly amongst herbalists. Some people will take the side that, as long as it's the plant, it's got the energetic signature, if you like, it doesn't really matter about the chemicals. One side of the spectrum. The other side will say, at the other end will say, look, it's about everything being standardised and replicated. My sense is, as long as if we take a sort of a balanced point on it, it would be that we want to obviously use standardised extracts, having enough of the marker compounds. So in the case of St John's wort, obviously hypericin and the flavonoids. Hyperforin also is quite active, but as we know, there's been studies showing preparations without hyperforin still having antidepressant effects. And obviously there's issues with drug interactions if there's higher hyperforin. So I guess the idea is, and this is probably an overall comment for herbal medicine quality, is just to make sure that the extract actually contains the phytochemicals. I mean, we need to have something in there or it's not going to have any effect. For there to be maybe standardised for a few key markers, not less than a certain amount. And just to make sure when they're doing the HPLC that you can see that it really does have a broad spectrum of the phytochemicals, and that some of these, as I said, these active constituents or marker compounds, at least are containing a certain amount. I mean, I don't think we're ever going to get it perfect, but as long as we can have some quality assurance in that area, especially with St John's wort, I think we can be reasonably confident that we're going to get a decent result.
I totally agree with you that, I think we need to give credence and homage to the beauty and the history of the herbal use, but we need to bring it into a modern age. So this standardisation issue is certainly a double-edged sword. It's not necessarily the active, but a marker compound.
Well, some of them can be considered active compounds when we do the preclinical research, and we see unless we have that particular constituent in there at that particular level, it's not going to be effective, and that isn't active, and I think we have to respect that. For example, sirimarin or the flavonolignans in Samaria's thistle. However, there's other cases where we really don't know what's working, and it is ultimately, in most cases, the synergy of the all the chemical entities interacting, and that's the beauty of nature. Is that a lot of the time the components as one whole are a lot more potent than the individual isolates in terms of efficacy. So you pull one out, and it just doesn't seem to have the same effect as, if you like, Mother Nature intended. And that's just there's something pretty special.
Let's moving on now to one that I know that you've got a special place for, and that's saffron. We'll move on to your favourite a little bit later, but saffron. Tell me about this, because the research on this is quite exciting.
Oh, look, it is. It's ongoing. I mean, it has to be said that the research, from what I can see, is just primarily Iranian, which is fine. I mean, it's a traditional Persian medicine. I think we really need to replicate a lot of the positive studies that are coming out of Iran in other populations. But yeah, some really good evidence for saffron with improving mood. It's been shown to be equally as efficacious as antidepressants in terms of relieving depression. It's also been shown to have an effect beyond placebo. So, certainly very good evidence. Can be expensive, but then some studies are showing that you can use the petals and have still some effect. You don't have to use the very expensive stigma. And look, it's certainly something which I think we'll see increased research and use. So it's quite an exciting antidepressant.
Any caveats, any cautions, contraindications with saffron?
Well, apart from cost and quality, and I would be obviously looking for extracts which do standardise for some of these known actives, the crocin and the safranel. But in terms of cautions, look, it tends to be, from what we've seen in traditional medicine, to be more of a stimulating agent. Mm-hmm. So perhaps in people who have comorbid anxiety, it has been shown in some studies to have an effect beyond placebo in increasing agitation and a little bit of anxiety in some people. But that's not a bad thing, because you're wanting some form of a stimulatory effect in people who have depression.
Yeah.
So I'd probably just caution with insomnia and anxiety.
Yeah, right.
Apart from that, should be quite safe.
Yeah. And now on to one that I know that you're interested in. That's Albizia julibrissin. Tell me about its common name, and tell me about some of the exciting things that are happening with that.
Happy bark, or the bark of happiness, recently been started to be studied a bit more scientifically. And then there's a lot of traditional Persian evidence and Oriental medicine evidence in terms of its use for mood and anxiety disorders, for improving sleep. There has been some animal models and in vitro models showing that it does actually reflect an antidepressant effect and also an anxiolytic effect. And there are some nice neurochemical studies showing that it modulates serotonin pathways, increases, has binding affinity, I should say, with 5-HT1A and 2C receptors. So there's certainly a serotonergic activity happening with it. And that tends to reflect the animal models, which is sort of showing that, yes, it can have a mood-improving effect, a calming effect, but also it's prolonged sleep time as well in animals. So very interesting. We haven't seen any human clinical trials yet, and we'd certainly love to do a human clinical trial if somebody gave me funding for it. But yeah, certainly based on some of the preclinical evidence and the traditional evidence, is something which is quite an exciting addition, really, to to any treatment of probably the presentation where somebody may have more of a sleep difficulties, some anxiety, potentially some low mood. It doesn't, I wouldn't have thought, have the stimulating properties of saffron. So I guess you'd say it's kind of a nice balance in terms of saffron being a bit more stimulating for mood, the albizia having an effect on mood, but perhaps more in a calming way.
And a beautiful adaptogen that sort of came onto the Australian market in the mid-2000s was rhodiola. And it's got some really lovely sort of stress adaptation actions. But tell me more about that herb. What's your knowledge of this with depression? Because there was some preliminary studies done on this.
Sure. Well, I mean, that's the problem with rhodiola. I mean, a lot of the research originally was Russian in origin. I actually had a supervisor many years ago, had a contact in St. Petersburg, and said, well, that's it, we will try to track him down, we're going to get hold of this Russian research. I sort of could imagine him going through the Kremlin, and sort of trying to find this ancient Russian, well, it's meant to be all on cosmonauts, and I mean, I don't know if they have cosmonauts anymore, but anyways, that's how old it is. But yeah, look, you can't get really hold of that particular research. I mean, it sounds very, very positive in theory. There's been one small study showing that it has been effective in improving mood in major depressive disorder, but it should be said that the placebo response was very flat, which is unusual. Usually people in a placebo group will have some drop in their depression because they're taking something. Yep. And the difference really in terms of the actual effect over time from the rhodiola was pretty minor in terms of depression. So my personal sense is it's not a strong antidepressant. I think that if it's used in combination, say, or comorbidity, I should say, with chronic fatigue, or a person who presents with really low energy and drive, maybe sort of more of your atypical depression, then it can be a very valuable addition. I think it can have some mood improving effects, but probably its primary attribute is as an adaptogen. Yeah,
and I did like your point there that with regards to studies, and how to read studies, how to tease out, the real information from studies. When you see either a very low placebo or an extremely high placebo, tell me what sort of red flags wave with you.
Yeah, I mean, generally you are expecting some drop in the placebo group of depression if they're in a clinical trial. If you get too much of a response with the placebo, then you can question potentially whether this group was really clinically depressed. Because people who do have long-standing, ongoing depressive symptoms, as soon as you give them a placebo, they really shouldn't, feel the best of ever felt in their life.
Yeah.
So, that's the issue. I mean, there's a point which goes beyond that, which is that a lot of the failed trials which we're getting with antidepressants is not so much that the antidepressants don't work, because they do work, and they certainly do work in a lot of people who have more severe levels of depression. The issue is that you get people coming in with sort of that mild to moderate depression, maybe some, maybe not true clinical depression, maybe say they've had a hard week, or, they're dealing with various sort of psychosocial stressors, but it's not necessarily a frank biological depression. Mm-hmm. And those sort of people potentially will not benefit as much from medication. So they're coming into clinical trials because there's a lot of incentive, financial incentive for centres to recruit people. Yeah. They're recruiting the people who, really have maybe done dozens of trials. Some of these people are trial aficionados, so they'll go out there and they'll do it for the money. So the issue is that we're not getting the people who we used to get 20 years ago, who really were medication-naive, depressed patients, mm-hmm. who suddenly get an antidepressant and, wow, they get a fantastic effect. We're not getting that with our clinical trials. So it's very hard to tease apart the result from placebo. And I think, to be honest, in some respects, maybe we're getting the same with some of the natural product trials. The only thing I'd say is that we probably have an advantage in doing natural product research with depression, because a lot of these people, haven't tried or don't want to try antidepressants. So at least when you come in with a medication, be it natural or otherwise, they will you've got a chance to actually see whether it is having a biological effect.
So let's move over to a very common nutraceutical that's used, and that's S-adenosyl methionine, or SAMI, in depression and certainly chronic pain. Tell me about your use with that, because you're doing some research at the moment.
Yeah, absolutely. Look, we're doing some quite exciting research in concert or support from Bioceuticals and the Blackmores Institute. We're quite excited with that partnership because we've produced a very high-quality SAMI preparation, which also has in it active folic acid, which is, in this case, folinic acid. And the clinical study which we're doing at the moment is actually comparing SAMI versus a combination nutraceutical containing SAMI, 5-HTP, EPA, the esters form, as well as zinc, picolinate, which is quite absorbable, mm-hmm. And just a little bit of the trace elements which help with the pharmacokinetics. So that study's ongoing, and we want to see whether, compared to placebo, we can get an effect in one group who will be taking antidepressants to see if they're still depressed. If they're taking antidepressants, can we actually improve these people who tend to have quite severe levels of depression? And also we're looking at it in a group which aren't taking any medication at all. So very exciting at the moment doing that. But in terms of SAMI itself, there's some very good evidence that it is, as a monotherapy, quite a robust and potent antidepressant, and also can improve people's response to antidepressants. So people who are taking medication, quite depressed, still aren't getting the result which they need. It tends to have an effect even beyond placebo.
And just lastly, a point on a couple of herbs which, I think practitioners get a little bit confused about. Traditionally, hops was sort of contraindicated in depression, and kava is commonly used for anxiety, and yet, you get an anxiety component of depression. So can you talk a little bit about use, contraindications and cautions with those two herbs?
Yeah, absolutely. Well, look, hops is obviously traditionally contraindicated in depression, and that's fair enough. I mean, I think it tends to for it to have its major effect to do with sleep disorders, because it's a binder to the melatonin 1 and 2 receptors. It's also hypothermic, so it reduces people's body temperature, which is important to initiate sleep. But you really wouldn't want those activities if somebody was experiencing depression, especially sort of depression where they're presenting with fatigue and lassitude. In terms of kava, in respect to using it for depression, just like with hops, it's certainly contraindicated. However, the other point to do with that is if a person presents with anxious depression, so they've got low mood, but it's co-occurring with anxiety, and probably the major driving aspect of their symptomatology is the anxiety, and perhaps from the anxiety they're getting a bit of low mood, then kava can still be used. There's no problem with that whatsoever. I should also say that St. John's wort, sometimes sort of bandied about as a great anxiety treatment. Really, there's no evidence to support that. I mean, from what I understand, traditionally even, it doesn't tend to be seen as an anxiolytic. And if you look at the evidence to do with particular disorders such as OCD and social phobia, the RCTs haven't shown any effect beyond placebo. So for me, pretty much St. John's wort is all about depression. I'm not saying that it may not have a synergistic effect with other herbs to improve anxiety. But if you look at one of our studies, which we conducted at UQ, combining St. John's wort and kava, it didn't tend to be effective in reducing anxiety in people, I should say, with major depressive disorder.
Right. What were the results of that study?
Yeah. Well, the issue was we chose a sample of people who had major depressive disorder, so they're quite depressed, as well as having high levels of anxiety. And we thought, well, St. John's wort good for depression, kava good for anxiety. Gave the two together, but certainly the results did not show that it tended to reduce their anxiety. I think nor overall treat their depression in the first phase, because it was a crossover study. I won't go into it too much, but did show that it was actually effective in the first phase for decreasing depression. But this wasn't replicated in the next phase. So the sense we got from it was, well, this is a tough group to treat. And so I think practitioners need to be aware in terms of some of the limitations of what we do, but also the need to have an integrative approach for mental health, because if people present with multiple comorbidities, so they may be depressed, they may have panic attacks as well, sleep issues, when you start getting to that level of comorbidity, unfortunately, it is a tougher group to treat, and we do need to help with psychological interventions as well as lifestyle, and to have sort of more of an integrated approach.
Okay, so just a clinical note for practitioners with regards to the use of these herbs and nutrients in pregnancy. So we know that fish oil is certainly indicated in pregnancy. Can we go down the list? St. John's wort in pregnancy?
I'll go and say this, down the list. Look, without even going down the list, I can say that unfortunately there isn't a lot of safety data on most of the nutraceuticals. And in fact, even something like St. John's wort is generally contraindicated in depression, however, in pregnancy. However, a lot of the time it is based on a caution rather than actually hard evidence from an animal perspective or a human perspective. The only thing I'd say in terms of pregnancy, apart from sort of obviously good multi, is omega-3 fatty acids.
Yeah. What about SAMI?
Yeah, look, that's one thing to my knowledge is certainly not given the absolute green light in terms of using it for depression, for pregnancy.
Yeah.
I mean, my sense is that I cannot see it being necessarily harmful to the unborn. However, to my knowledge, it certainly isn't given medical clearance in terms of use in a pregnant population.
Yeah, so I think the caveat would be they may not be directly contraindicated for evidence of harm, but you have to carry the caution that it may not be beneficial and may cause harm, so you have to do that risk-benefit. Would you agree with that?
Yeah, that's right, and that's why there needs to be obviously professional advice on whether to take these nutraceuticals for pregnancy. It's not something which certainly I can sort of advocate over a podcast, they must obviously take professional advice on their particular situation.
Wholeheartedly supported.